Congestive heart failure treatment in the context of low blood pressure and heart rate. Managing congestive heart failure, CHF, requires a nuanced approach, especially when patients present with low blood pressure, BP, and heart rate, HR. Tailoring therapy to alleviate symptoms, enhance quality of life, and improve survival is paramount. This article examines the effects of common CHF medications on BP and HR, emphasizing strategies to optimize treatment while minimizing risks, particularly in older adults or those with pre-existing low values. Notably, the cornerstone of initial therapy for many CHF patients, particularly those with heart failure with reduced ejection fraction, HFrEF, often involves medications like angiotensin-converting enzyme, ACE, inhibitors and beta blockers, which require careful consideration in the context of low BP and HR. The importance of individualized therapy. Personalized care is essential in CHF management. Factors such as the type and severity of heart failure, the patient's age, baseline BP and HR, coexisting health conditions, and medication tolerance all influence therapeutic decisions. Patients should never initiate, discontinue, or alter their medication regimen without direct consultation with their cardiologist. The initial approach might involve ACE inhibitors, like lisinopril or enalapril, to help relax blood vessels, and beta blockers, like carvedilol or bisoprolol, to slow heart rate and reduce cardiac workload, but these must be introduced cautiously in patients with low baseline values. While this article focuses primarily on HFrEF, it is important to recognize that management principles differ in heart failure with preserved ejection fraction, HFpF, where volume control, blood pressure optimization, and comorbidity management, e.g., atrial fibrillation, diabetes, play a more central role, and guideline-directed medications may have more modest survival benefit. Medication effects on blood pressure and heart rate. Understanding the impact of CHF medications on BP and HR is crucial for safe and effective treatment. Impact on blood pressure, most to least lowering effect. ARNIs, e.g., sacubitril/valsartan significantly lower BP by enhancing natriuretic effects and reducing vasoconstriction. Increasingly considered, even as a first-line option in some cases. ACE inhibitors, e.g., lisinopril, enalapril lower BP via vasodilation and reduced fluid retention. Often a first-line treatment for CHF. ARBs, e.g., losartan, valsartan decrease BP by blocking angiotensin II. May be used as an alternative to ACE inhibitors. Beta blockers, e.g., carvedilol, bisoprolol, metoprolol reduce BP by slowing the heart rate and decreasing contractility. A crucial first-line therapy for many. Diuretics, e.g., furosemide, hydrochlorothiazide lower BP by decreasing blood volume. Soluble guanylate cyclase, SGC, stimulators, e.g., vericiguat cause moderate BP reduction through vasodilation, enhancing the cyclic GMP pathway to relax blood vessels. Used in patients with symptomatic chronic HFrEF who have recently experienced a worsening event. SGLT2 inhibitors, e.g., dapagliflozin, empagliflozin modestly lower BP via osmotic diuresis and natriuresis. Now considered a key component of CHF management, often added early in treatment. Digoxin, minimal direct impact on BP. Positive inotropes, e.g., dobutamine, milrinone may raise or lower BP depending on the specific agent and patient response. Impact on heart rate, most to least lowering effect. Beta blockers significantly reduce HR by blocking sympathetic nervous system activity. A first-line agent requiring careful titration in patients with low HR. Digoxin lowers HR by enhancing vagal tone, particularly in atrial fibrillation. Non-dihydropyridine calcium channel blockers, e.g., verapamil, diltiazem. Though not standard for CHF, they can lower HR when used for comorbid conditions. ARNIs, ACE inhibitors, ARBs, diuretics, and SGLT2 inhibitors typically have a neutral effect on HR. Soluble guanylate cyclase, SGC, stimulators, e.g., vericiguat usually neutral or mildly increase HR. Positive inotropes vary, though butamine may raise HR, while others may have minimal or inconsistent effects. Clinical concern, low BP, low HR, and fatigue. When a CHF patient presents with both low blood pressure and a markedly low heart rate, such as a resting HR of 40 beats per minute, accompanied by symptoms like fatigue, this raises an urgent clinical concern. A heart rate below 60 bpm is classified as bradycardia, and a rate of 40 bpm is significantly below that threshold, potentially resulting in inadequate cerebral perfusion and reduced cardiac output. While hypotension is a well-known contributor to falls, it is equally important to recognize that severe bradycardia also increases fall risk by causing dizziness, lightheadedness, and even syncope due to reduced brain perfusion. In patients with CHF, the combination of low BP and HR is particularly hazardous and may be exacerbated by medications such as beta blockers or ARBs, often used when ACE inhibitors are not tolerated. Immediate cardiology evaluation is necessary to assess for medication-induced bradycardia or conduction abnormalities and guide treatment adjustments. The initiation of even first-line therapies like ACE inhibitors and beta blockers requires careful titration and monitoring in such patients. Strategies for managing CHF with low BP and HR. In situations involving low BP and HR, especially in older or more fragile individuals, clinicians should take a conservative, well-monitored approach. Immediate communication, report abnormal vital signs and concerning symptoms to the cardiologist without delay. Medication reassessment, evaluate all current medications, including first-line agents like ACE inhibitors and beta blockers, for their potential effects on HR and BP. Dose reductions or discontinuation of contributing agents may be necessary. Cardiac monitoring, use ECG and possibly Holter monitoring to evaluate for arrhythmias or conduction disturbances. Gradual adjustments, any medication changes, especially when initiating or adjusting foundational CHF therapies, should be made incrementally, with close monitoring to assess response. Alternative agents, consider options with a more neutral profile, such as SGLT2 inhibitors, which exert modest BP effects without significantly lowering HR and have become a crucial part of modern CHF management. ARBs might be considered if ACE inhibitors are poorly tolerated but still require careful monitoring of BP. In some cases, ARNIs might be used but their impact on BP needs close attention. Role of device therapy, pacemakers/ICDs for patients experiencing persistent, symptomatic bradycardia, low heart rate, that cannot be safely managed with medication adjustments, e.g., if foundational CHF medications are essential but cause profound bradycardia, the insertion of a permanent pacemaker may be considered. A pacemaker delivers electrical impulses to maintain an adequate heart rate, improving cardiac output and alleviating symptoms like fatigue, dizziness, and syncope. In specific CHF patients, particularly those with reduced ejection fraction and certain conduction abnormalities, an implantable cardioverter defibrillator, ICD, might be indicated to prevent sudden cardiac death, often combined with pacing capabilities. These devices are typically considered after medication optimization and a thorough electrophysiology evaluation. Falls prevention. Patients with low heart rate and/or low blood pressure are at increased risk of falls due to poor cerebral perfusion, dizziness, or fainting. Implement strategies such as encouraging slow, deliberate changes in posture, e.g., rising from bed or chairs slowly. Reviewing and optimizing the home environment for safety, e.g., removing tripping hazards, adding grab bars. Using mobility aids as needed. Monitoring hydration and electrolyte status. Educating caregivers and patients on early signs of hypotension or bradycardia-related symptoms. Recognizing bradycardia, not just hypotension, as a fall risk factor is essential to preventing injury and maintaining patient independence. Measuring orthostatic blood pressure and heart rate, supine, sitting, and standing, can help identify postural instability and guide adjustments in medications or hydration strategies. Broader patient management considerations. Fluid and nutritional management. While diuretics help manage fluid, a careful balance of fluid intake is crucial. Excessive fluid restriction can sometimes exacerbate hypotension, while uncontrolled intake worsens congestion. Patients should be educated on appropriate sodium restriction and fluid monitoring. Multidisciplinary team approach. Optimal CHF management, especially in complex cases, often benefits from a multidisciplinary team including cardiologists, nurses, pharmacists, for medication reconciliation and education, physical therapists, for mobility and fall prevention, and nutritionists. Patient education and self-monitoring. Empowering patients through education is vital. This includes understanding their medications, the importance of daily weight checks, recognizing signs of worsening CHF, beyond just low BP/HR symptoms, and knowing when to contact their healthcare provider. Patients should also be encouraged to report all medications, including over-the-counter drugs and supplements, to avoid adverse interactions. Addressing mental health. Living with a chronic condition like CHF, especially with challenging symptoms and complex treatments, can take a toll on mental well-being. Healthcare providers should be mindful of screening for and addressing anxiety and depression, which can significantly impact quality of life and treatment adherence. Goals of care and prognosis. For some patients, particularly those with advanced CHF and multiple comorbidities, discussions about prognosis, advanced care planning, and aligning treatment with individual patient goals and wishes become paramount. In patients with advanced CHF and frequent hospitalizations, early integration of palliative care services can support symptom control, advance care planning, and improve patient and caregiver quality of life. Hospice may be considered when CHF becomes refractory to medical management and aligns with the patient's goals. Screening for cognitive changes. Prolonged low cardiac output states may contribute to cognitive impairment, which can further increase fall risk and complicate self-management. Consider screening for cognitive changes, especially in older adults with significant bradycardia or hypotension. Conclusion. Effectively managing CHF while addressing concerns about low BP and HR requires a personalized and proactive strategy. A heart rate significantly below normal and symptoms like fatigue are warning signs that must not be ignored. Open communication with the cardiology team, careful medication management, including the cautious initiation and titration of first-line therapies like ACE inhibitors and beta blockers, and close patient monitoring are critical to ensuring safety and optimizing outcomes. The integration of newer first-line agents like SGLT2 inhibitors also provides valuable options in managing this delicate balance. In cases where medical therapy alone cannot adequately address symptomatic bradycardia, the judicious use of device therapy such as pacemakers or ICDs may provide a crucial lifeline, improving both symptoms and quality of life. Early recognition and response, coupled with a comprehensive, patient-centered approach, can make the difference in preventing complications and preserving quality of life for patients with this complex condition.